Good evening and welcome to this edition of our YouTube channel, Pain Free Partha. Today I'm going to talk something about referred pain. Okay, still we have not clearly understood what exactly happens in referred pain. Anytime I talk anything on academics, a good salute to the legendary teacher of 2 centuries. What is that referred pain? Now, if pain is perceived at a location other than the site of painful stimulus, that is one point. There should not be any continuation. Okay, now there is an injury here and a pain is here. Now there is an injury in the elbow and a pain is in the wrist. Then it becomes a referred pain if there is no continuation here. So that is what is a pain. Referred pain. A painful sensation reported in the region other than that which a noxious stimulation has taken place. Noxious stimulation means injury or whatever it is. That is what is called the referred pain. Now we will go into what is radiating pain and referred pain. Okay. Pain of myocardial infarction is located in the mid or the left side of the chest. That is okay. But it can also radiate to the left side of the jaw and left arm. Sometimes it may not be there. The referred pain only will be there in the jaw or the left arm. But it may not be there in the chest. That is what the subtle difference they give between radiating pain and the referral pain. Even the International Society of Study of Pain is not very clear about what is radiation pain and referred pain. Whatever I have understood is the referred pain, there is no continuation. Okay. Now there is a chest pain or may not be a chest pain and the jaw is having pain and the patient is having an ischemic heart disease. Then it becomes a referred pain. Referred pain is very common. People think that referred pain is uncommon. That is absolutely wrong. Referred pain is common than most of the big common so-called syndromes, I'll say. In you see here, reported 17 to 84% of patients with leukemia. Researchers study neuropathic pain. Researchers study so many biofeedback pain theories and all. But usually, referred pain is less researched. The liver and gallbladder, you can have referred pain here. Small intestine here. Appendix, stomach can be here. Pancreas can be here. You can see urinary bladder can be here. So these are all the common referred pain regions. What are the clinical features? Okay, I am telling this is a vague, a poorly defined sensation and transitory. There may be emotional reactions followed by pain in the referral area and becomes intense and continued stimulation slowly goes on to referred hyperalgesia. What is hyperalgesia? A painful stimulus it producing pain is algesia. A painful stimulus which is producing pain which is cut by narcotics is analgesia. Okay, whenever pain producing substances is called algogens. Algesia is pain. Hyperalgesia means what? You have painful stimulus, but the response is too much. So you can have, even in the referred pain area, there may be referred hyperalgesia. So you can have both referred pain with or without hyperalgesia. There may be history of trauma or infection, a visceral disease. Just we should see whether there is inspection for inflammation, anything, examination for visceral disease. Then go on tests for hyperalgesia, a simple digital pressure. They are not very clearly 100% true, but superficial pain is this thing less likely referred. A deep pain is more likely referred. A distal pathology is more localizable than proximal. Tenacious pain is more likely to be referred. These are all some tips to know that this may be a referred pain. Chest sinus pain in the left shoulder. That is what we have been taught in the MBBS. This is indicating of rupture of spleen here and the patient gets pain here. What happens if we give interscreen block now? That is one question. It may persist or sometimes we may not know. So that is one subtle difference. Sometimes even in interscreen block, the referred pain may not go. Brain freeze is caused by spinopalatine ganglion nerves located behind the nose. They cause headache, cold headache, possibly there is a CNS vasodilatation. They come and go fast. There is no other symptoms. The moment you start to experience a brain freeze, press your tongue like this. The heat from your tongue will transfer heat and energy to your sinuses. Probably the nerve bundles behind relatively warm. So until your pain starts to get decreased. Like that. So what they say is வாழ்க வளமுடன். வாழ்க வளமுடன், the tongue will press onto the palate. Phantom pain is an ultimate referred pain. First of the pain is obviously not where the pain is originating because there is no place only. So we will take phantom pain and the other theories of phantom pain in a separate video. If we give additional nociception in the referred area, the response is less. I'm not talking about patients with hyperalgesia. Descending inhibitory control may explain the decreased response. So, in the referred area, the descending inhibitory control is good. In the pain area, it is not so. So, if you give additional nociception in the referred area, it makes less. But that is what is pressure induced is expanded by persistent soreness. Now we have shoulder arthritis. Pain is referred to the elbow. The area is 4 by 4 centimeters. Now it expands here. Now the referred pain is from here to here, from here to here. Then it means there is some problem and there is a danger of central sensitization. Now you have got an ureteric stone, calculus, operated, or it may be spontaneously expelled. Hyperalgesia is still detectable in the oblique musculature ipsilateral to the previous in most cases. We have seen so many patients, ureteric colic, patient is fine, and still this again small stones, you will go on complaining. That is very classical of referred pain because of ureteric stone which is past. Now we go to osteoarthrosis of the knee. Deeply, fairly well localized, sometimes thigh and back muscles, and sometimes below the knee also. There may be atrophic changes in the skin and muscle. So this is one example. Now we have pain in the teeth. If your upper teeth are painful, your nasal passages are congested, your toothache may be due to sinusitis. Filling in one tooth, the other tooth may ache. Tooth abscess can be referred to ear. Headaches may be cause of tooth pain. TM joint may be tooth pain, or sometimes a heart problem may cause a tooth pain. So pain in teeth, think of it. So many referral, sinus. You can have tooth abscess to here, headaches, toothache, heart problem, toothache, TMG joint, toothache. So many causes of referred pain in the teeth, and teeth problem can cause referred pain in the ear. Why should we get? Somebody doesn't get, somebody gets. Why should that be like this? Now, what are the so many theories? Because if you already I have told in theories of pain, if there are so many theories, that means we have understood less. Involvement of adjacent somatic structures cause pain. Simultaneous can be the only symptom put to disuse. A very simple theory. Here there is injury elbow. There is some involvement of the wrist also here. That is a very simple theory of referred pain. Marley's theory, and it cannot be simultaneous. So this theory is put to disuse. What is the axon reflux theory? Now you see viscous appendicitis is causing pain, or cholecystitis is causing left shoulder pain. What they say is the sensory neurons have got bifurcating axons. So the dorsal horn, it's so an noxious stimulus is perceived in the skin like this. So this is what is called axon reflex theory. But there are no such axons and no explanation to time delay. After some time only, the referred pain takes to go on. So this time delay is not explained. There are no such axons, no explanation for referred hyperalgesia. So axon theory is gone. This is convergent projection theory of Roche. Visceral and somatic primary sensory neurons converge into a common spinal neurons. Now the ascending spinal pathways confused. So that is what is called the convergent projection theory. See here in the dorsal horn, from the viscus and from the skin, from the dorsal horn it goes. So there is pathways are misconstrued like this. Sometimes you can get a lot of calls from here because of some convergent projection of your telephone lines. So this is convergence projection theory. Now we have got McKenzie's convergence facilitation theory. What he tells is completely different. He tells viscera are insensitive. The visceral afferent activity basically never gives rise to pain. It creates an irritable focus in the spinal cord, and that is why it is called referred pain sensation. Now you see, this was directly convergence, but here there is a separate place, viscous, and this has to facilitate this to cause a pain here. This, what is this? Here, what he tells is viscera are wholly insensitive. That is gone. So it is not possible. But there is one explanation. The referred pain comes after some time. So viscous is a problem. It takes some time to do this facilitation so that the skin gets pain, referred area gets pain. So this explanation is given by this convergent facilitation theory. No general acceptance. Our theory offers an explanation for referred hyperalgesia. The concept of irritable focus has been resurrected with central sensitization, a major importance in hyperalgesia. Supraspinal theory of Theobald. Now you see, first we saw here this, then we saw here this, then we saw here one facilitating. Now we saw that's a brain. Convergence takes place here. Is there separate systems is questionable. Now there is a neuropathophysiological model. What does it tell? Now we have got a local pain here. There is a problem with the spine. This local pain has got, see here, why it is latent excitatory, inhibitory. It stimulates, we have got pain now. Now this also stimulates after a latent period, and thereby we get pain here, referral pain. So this is what is the neuropathophysiological model of referred pain. There are so many names. Iman and Saunders suggested that referred pain followed by a distribution of sclerotomes, not dermatome. He says muscle, fascia and bone. Sclerotome and not dermatome. Somebody called it as Hushman thermatomes. Circulatory distribution of sympathetic nerve area. That is what he told. So the diagnosis is not all that simple. Now we see a tenacious pain, little deeper pain. We have got an initial pathology. For example, we have got an appendicitis or we got a cholecystitis. Now a tenacious pain which is so deeper in the shoulder, then it means possibility of referred pain. So these are the differences between referred pain and radicular pain. So distribution pattern, secondary hyperalgesia. Here you can see weakened reflexes. All these things will not be there. The exogenous model is most used is the intramuscular infusion of hypertonic saline. Into the muscle you put hypertonic saline. Now after the infusion, the referred pain will be felt as structures distal to the infusion site with a delay of 20 seconds. Local pain acts at this and 20 seconds later this is what is the clear-cut model of referred pain. Just inject hypertonic saline into the muscle. Intramuscular hypertonic saline, pain at the muscle, and 20 seconds later, pain at the referred area. Distinguish pain referral to a tooth as distinct from pain arising in the. Sometimes you give local in the tooth. Referred pain means it stays. Okay, that's what I have already told. Interscalene block. What happens here? Such a clinical finding alert clinicians of the possibility. Now the patient is having toothache. Now you give local. Toothache remains because the problem is TMG. That is a very simple diagnostic test. Another method is to use intramuscular, already we have told intramuscular hypertonic saline. Now intramuscular electrical stimulation. Again the same thing. Positive correlation between the stimulus intensity, local pain and referred pain. This is what we want to tell. If you give a stimulus, the local pain will be there, and after 20 seconds, the referral pain will be there. The muscle pain, the referral pain. They increase the thickness of the subcutis and decrease the thickness of the muscle. So these are all things in ultrasonography which we can say that it gives a clue to a referred pain. CT, MR, all these things are not useful. Now, if we anesthetize the site of pain, will the referred pain stop? So it depends upon the number of structures. This is most important because referred pain areas are commonly located to be deep tissues where complete anesthesia is difficult. The duration and level of local pain. The site of local pain. Whether sensory changes occur. Now, I am very clear here. What is the question? Now there is an elbow area injury. We have got a referred pain in the wrist. Now what my question is, if you give anesthesia to the elbow and not to the wrist, will the wrist pain decrease? So this depends upon how many days before there is, how many intense this is, and how far there is a referred hyperalgesia. So this area itself is become hyperalgesic, then there is no response. But if you give initially elbow block, your wrist pain is likely to decrease. Subanesthetic doses of ketamine. Apply EMLA cream above the referred pain area. Ethyl chloride, tourniquet alone or IVRA with it. Intravenous regional anesthesia in the referred pain. Intra-articular injections of steroids have been used to treat facetogenic pain. Radiofrequency has been facetogenic and sacroiliac referred pains. Intradisc, for example, now you have a spine problem or a disc problem that is causing pain here, somewhere in the thigh. So now you treat the do a plasty of it or do some disease, cure the disease or whatever, treat the facet joint, treat the sacroiliac. Definitely your referred pain is likely to decrease if it is not beyond that so much. That is what I explained. Discogenic granic brain lumbar disc surgery, kyphoplasty. Patients with referred pain have got better outcomes after spinal surgeries. We can use acupuncture. We can use trigger point injections. We can use laser ultrasound. We can use heat ice. These are all the other treatment modalities. Get the intensity of the original pain down. That is very important. Original pain is continuous, then unlikely we can treat the referred pain. Get the original pain down and make it discontinuous, then your referred pain is likely to be cured easily. A 29-year-old male was operated for ureteric colic in 2019. But continuous pain, this is 2023 now. 4 years having cane. Clinically, USG is normal. I have started him on dextromethorphan and the patient is saying slightly better. Possible diagnosis, possibly is having persistent referred pain. A 46-year-old female with osteoarthritis of the knee, severe, not decreased, then give 1 shot of steroids, but pain in the lower thigh and lower leg persistent. Hyperalgesia in the thigh. All these things were there. No pain on the movement of the joint. Possible diagnosis, a persistent referred pain. I gave flupertin and dextromethorphan, and I did acupuncture also. After that, patient became better slightly in terms of satisfaction and in terms of pain relief. A 75-year-old male has got constant backache, and the people have done a lot of MRIs. But actually, the ultrasound of the prostate was diagnostic. So referred areas of headache. You see here, so many areas of headaches is there. Here, suboccipital. I've done a lot of this. So many headaches. Give suboccipital half ml steroid with local. This is the referred pain here. This is sometimes your pathology may be here or referred area may be here. 60% of the TMJ have pain referred. See here, temporal, back, here, so many pains. See the TMJ, very important. So much pain, see the TMJ, see the tooth, all these things go by system examination. So ultrasound guided intraarticular steroid for temporomandibular joint arthritis. Here you can see temporomandibular notch. We can give steroids. The patient is usually better. Now we have got lap surgery. We get shoulder pain sometimes after pneumoperitoneum. Now what we have done is we give cervical plexus block, superficial cervical plexus block. It cuts down the superficial plexus because they have proved connections between phrenic nerve and cervical plexus. Phrenic nerve is bathed, so the afferent is decreased. Because superficial cervical plexus block, the phrenic is bathed. And also the cervical plexus is blocked. So the patient gets better pain relief, not much of post-lap shoulder pain. Now what I want, referred pain. What is it, referred pain? A pain in the area where there is no nociception and this continues with the nociceptive site. It is continuous with the nociceptive site, it is not that. And it is usually tenacious, slightly deeper. Features. There are a lot of theories. You can see axon reflex, Sinclair's theory, Rouch theory, Mackenzie's theory, Theobald's theory, here. So it means we have still something is elusive. Dynaneuropathic or non-nociceptive. We can see one umpire, he get into no ball and then became out and again kept no ball, something like that. So we are not very clear about what is what. Thank you all. Long live the ISA. All my slides are in painfreepartha.com and my channel. Subscribe and listen. Pain Free Partha in YouTube. Thank you.